Hi everyone, here with the next installment of Ultrasound of the Month. This one was performed by Doctors Cruz and Marco. This patient was an older gentleman but had minimal past cardiopulmonary history and came in very confused, tachycardic, tachypnic, and hypotensive. He had also just gotten back from a long plane flight and there was a high suspicion for pulmonary embolism. Given his instability, they performed a bedside cardiac ultrasound. As per usual, they started with a peritoneal long view. You'll notice here in our right ventricle, and here you see our left ventricle, and the right ventricle actually appears to be larger than your left ventricle, which shouldn't be. In a normal heart, the right ventricle should be 2/3 the size of your left ventricle. If you look closely, you'll also notice what appears to be the right ventricle bowing into the left ventricle, which is again abnormal. The peritoneal long view certainly isn't my preferred view to look for right heart strain, but these pictures raise my concern for it. So now we switch to the peritoneal short view. Again, we see a large right ventricle with a smaller left ventricle, and we see signs of right heart strain as it appears to be bowing from the right ventricle again into the left ventricle. This is sometimes known as the D sign, as the left ventricle, instead of squeezing like a concentric circle, gets squeezed like the letter D, as seen here. And finally, we'll look at the apical view. This view helps to confirm that the right ventricle is much larger than the left ventricle in this, and is atypical bowing, yet again seen here. There's certainly other measurements and calculations you can perform to look for a right heart strain, but looking for these previously shown things is probably the most practical for us. This ultrasound helped to essentially confirm that there was a PE with right heart strain from the first several minutes that they saw the patient. Alright, thanks again everybody.